Hi, I'm Dr. Nishant Yagnick. I'm the Marrow faculty for Neurosurgery, and today we are going to discuss the Neurosurgery recall questions from our 2022 NEET SS examination. Now, before we start, remember this was a general examination. For after a long time, they've had a general format for all specialties. So everyone who's given this examination, despite what their preferred choice of field was, has had to attempt these neurosurgery questions. And we'll discuss only the neurosurgery part of what we could get from our very dedicated students and some of our toppers as to what questions they were to recall. So let's start with the first question. We're going to do the tougher questions first. The first two are a bit tough, and they are the controversial ones as well. So the artery of Adam-Kiewicz supplies what? Now, basically, the artery of Adam-Kiewicz is the largest blood supply to the spinal cord. And we've discussed this in our marrow lectures from neurosurgery. And it's a very specially named artery, and we neurosurgeons love asking the questions on this artery as well as in their MCQs. Now, this is an artery that begins from the posterior intercostal arteries, which originate from the descending aorta, and it generally joins the spinal cord by anastomosing with the anterior spinal artery at the level of between T8 and L1. That's the classic description. And T8 is generally considered the level at which it joins the spinal cord, after which it supplies the lower thoracic cord, but it supplies the entire spinal cord, even at the level at which it joins and below. So the controversy part of this question is that there's two choices in this. The one is C and the other is D. Both are actually not wrong. It does not supply the cervical spinal cord, and it's generally believed not to have any anastomosis at the upper thoracic cord, although sometimes it can join high up, all the way up till T3, but those are uncommon anatomical variations. Usually it joins somewhere between T8 and L1, usually T8 to T10. So it definitely does supply the lower thoracic cord. So that would be my choice of answer, C. But you have to understand, when they say sacral spinal cord, they mean sacral spinal segments, which actually end at L1. Below L1, what we are seeing is actually nerve roots going all the way down as the cauda equina. These nerve roots are supplied by the vasa nervosa, which is what the supply for all nerves is. And these nerve roots then go all the way down from the spine, the vertebral column, and then they go into the respective spinal segments in the rest of the body. So the sacral spinal cord is also actually supplied by the artery of Adam-Kiewicz. But to make things very straightforward, the best answer would be lower thoracic, because what they want you to know is that they're actually the point at which it is actually joining the spinal cord. A few more important points of the artery of Adam-Kiewicz I'd like to let you know. The first is that it is a named artery because if this artery gets thrombosed, then it leads to an infarct of the anterior spinal cord. Second, it forms a very special hairpin loop. And this hairpin loop is used angiographically to mark where angiographic intervention is on the spinal cord. And that hairpin is very important. So you see, when you do a diagnostics angiography of the spinal cord to treat maybe a spinal AVM or any other spinal disorder, it's very difficult to make out what exact segment of the spinal cord you're in, because an angiography is done in a 3D X-ray. So you can count the vertebral bodies definitely, but it's not as simple when you're trying to put in a catheter. So when you can see this hairpin loop of the Adam-Kiewicz, which it forms at the anastomosis with the anterior spinal artery, you automatically come to know that this is around T8 to L1. So that's a sort of marker for you, and that's why this artery is named, and it's very important. And the answer to this question would be C, lower thoracic. Now, this is the other fairly controversial question. And the question asks that the patient has had an RTA 7 hours back and there is pain in the dorsal spine. NEET-SS protocol what would be the dose of methylprednisolone for the NEET-SS protocol? Now, very honestly, I did not know what the NEET-SS protocol was. I have done a separate entire lecture in our series on most important trials in neurosurgery. I have not included NEET-SS because NEET-SS is a very old trial. NEET-SS has always been done in three parts. Now, the first one was in 1977 and the second one was in 1985. And what we use now is the NASIS 2 protocol. There has been a NASIS 3 protocol after that, but it's not been as important as the NASIS 2 protocol. And NASIS, the full form is basically National Acute Spinal Cord Injury Study, conducted in 1985. Since then, there's been very, very important trials, and I'm very surprised that they've included this trial instead of the many other recent relevant, field-changing trials that have happened in neurosurgery. But still, they've done this, and they've done it very cleverly. You see, the choices they've given is actually what we do in practice. So what the examiner has tried to ask you is, he doesn't care if you know the NASIS protocol. The examiner wants to know whether you know how much methylprednisolone is to be given in a patient with acute spinal cord injury. So what you generally go in your residency is, someone will teach you that, oh, this patient is within 8 hours of a spinal cord injury, give this much methylprednisolone. And if you know this, then you know that this would probably be from some protocol. Even if you don't know the name of the protocol, then you know that this is the amount of dose to be given. Now, there is a further controversy in this, and that's why this is the most controversial question in this entire set. First, the NASIS protocol, being an older protocol, is supposed to be a bolus dose followed by a 24-hour dose, and that bolus dose is generally thought to be 30 mg per kg over 15 minutes. Now, they have not given the weight of the patient. So the answer would depend on what you consider the weight of the patient. And if it's a 60 kg person, then the weight would it comes out to be around 1.8 grams of bolus dose over 15 minutes. So now you can imagine that the controversy in this. They've given one choice of 1.5 grams, another choice of 2 grams. After this, there is a 24-hour infusion of 5.4 mg per kg per hour. And this 5.4 mg per kg per hour, again, it depends on what is the weight of the patient. Now, my answer to this question would be C. Although it is, again, you can say that it is a very controversial question. Because if I'm considering a 60 kg person, it's 1800. If I'm considering a 70 kg person, it's around 2 grams. But let us say that a 60 is usually the weight that we consider as an average weight, male, female. But if it's 70, I would say 2 grams. 1.5 grams is a bit less. And the 24-hour dose is also not exactly the clearest. So if the 24-hour dose, we have almost a 324 mg per hour dose over 24 hours. So I would not, for a 60 kg person, so I would not consider D as the right answer. My answer to this would be C. And very honestly, I could answer this question only because I have treated patients with methylprednisolone. I have not studied in detail the NASIS protocol. I have studied it for this exam, for this set of questions. But I knew the answer because that's what we do in practice. So if you want to know more about the NASIS protocol, the Nature paper, which summarizes the NASIS protocol, is a beautiful paper. I recently read it, and it's available online. Within 8 hours, it has been found that there is that if you don't give methylprednisolone in placebo patients, there is only a 20% recovery from a complete spinal cord injury and a 30% recovery in those patients who have been given methylprednisolone, and the dose is 30 mg per kg over 15 minutes, followed by 5.4 mg per kg per hour over 24 hours. So my answer to this question would be C, also, although it is debatable. Now comes to the rest of the questions, not a lot of questions, not very controversial questions. And these are the questions you cannot get wrong. So this is a question on GCS. We've discussed GCS in an entire lecture. The patient opens eyes to voice command, which is basically E3. E4 is spontaneous eye opening. E3 is to voice command. Patient is confused. So disoriented to time, place, and person is called confused. That is V4. V5 is oriented to time, place, and person. So confused means disoriented. V4. Localizes pain, M5. So it is 3 plus 4 plus 5. That's 12. So GCS score here is 12. The gold standard for visualizing of coronal vasculature. Now, there is some controversy whether it was a coronary vasculature or whether it was cerebral vasculature. So we've included the question anyways. The answer, whether you're doing cardio or whether you're doing neuro, is the same. It's an angiogram. An angiography, a digital subtraction angiography, is the gold standard for any angiogram done anywhere in the body. So the answer would be A, a coronary angiogram. If it was a cerebral angiography, then I would say digital subtraction angiography or DSA. Okay, another question, a bit again controversial. Radiating pain to upper limb, spasticity of both lower limb, level of lesion. Remember that if there is a lesion in any part of the cervical spine, it is a UMN lesion for the lower limb, and therefore bilateral lower limb spasticity will be seen in all the choices given, if these are the choices that are given. Now, radiating pain to the upper limb. This sort of rules out C3 and C4, although some radicals of C4 will go all the way up till the lower part of the shoulder. But C3 generally remains up till the neck. So it doesn't actually, you can't say upper limb exactly. On the other hand, C5 and C7 both are represented as dermatomes in the upper limb. So the answer can be either A, C5 or B, C7. Now, when it comes to this, I normally suggest that you answer B, C7. There's a reason for this. C5 is a perfectly good answer. But C7 is so commonly involved when it comes to cervical spine lesions that I would give the answer as C7, although C5 is a perfectly correct answer at the same time. So the answer is both A and D. But if this was the actual question, then I would say B would be my choice. Okay, so here we are given a CT scan, and there is it's a plain CT. There is no contrast given. Still, there is this mixed density, well circumscribed, slightly, I would not say enhancing, slightly hyperdense rim lesion with a lot of peripheral edema, a lot of it. So this, as you can see, so this is the lesion, and this is the edema around it, and it's causing a mass effect. And what is written is it's a single metastatic lesion with perilesional edema. So, number one, they've told us that it's a malignant lesion, so it's a metastasis. Number two, they've told us there's edema, although you can very, very beautifully see the edema here. What will you do? Will you give steroids only? Will you give mannitol? Will you give mannitol / hypertonic saline with steroids? Well, no neurosurgeon worth his salt will not give both things. See, steroids are definitely indicated. They work magically to reduce the edema of metastatic lesions in particular, which are not lesions of the brain themselves. They come from outside. So they cause a severe edema. It relieves patients significantly till the time that you can remove this lesion. This is a very operable lesion, by the way. It should be operated. And they come out very beautifully because they're very well circumscribed from the brain. So steroids are definitely given, but with so much edema, I would definitely give mannitol and hypertonic saline at the same time. So now the unknown neurosurgeon worth his salt or her salt will not give mannitol and hypertonic saline along with steroids in a scan such as this. No one will say only steroids. So the steroids are the best answer. But I would definitely give it, and I think nationwide, everyone I've worked with would definitely give either mannitol or hypertonic saline. Usually, we just give mannitol in India and steroids with this lesion. So my answer to this would be C. Okay, following an RTA, a patient is unconscious. There's no deficits. CT brain is normal. What is the next step in investigation? Now, this is a very interesting question. First, the patient is unconscious. So how do you check for deficits? You can at max check for GCS. But when we say no deficits in such a question, we generally mean that we've given the patient some pain stimulus and both sides are moving. So that means it doesn't seem like there is any spinal cord injury or anything like that. The CT brain has come out to be normal. So how come the patient is unconscious and we're assuming they have a head injury? So the answer is that the patient has a diffuse axonal injury, which is not very easily picked up on a CT scan. So the next step is an MRI. And they've given two choices of an MRI here. Definitely not a CT with contrast. An MRI with contrast will show nothing. What you need to see for a diffuse axonal injury is whether there are small microinfarcts at various points in the brain. So the answer would be A, MRI with diffusion weighted imaging, because diffusion weighted imaging is one of the best sequences to pick up tiny infarcts, even the tiniest of infarcts. And remember, DAI has multiple grades, sometimes can be seen on CT as well. Grade 1 is when these small infarcts or small tiny hemorrhages are there in the upper part of the brain, the parenchyma of the brain, the lobes. If they're seen in the corpus callosum as well, then it's grade 2. If it's seen in the brainstem, it's grade 3, which is a very poor grade. And in all these cases, it's very easy in the CT to miss it because there is no gross significant edema or no gross significant infarct or clotting. So MRI diffusion weighted imaging is the diagnostic investigation of choice to rule out or to diagnose a DAI. And there's a very classical description of this, of what is called, it's called a starry sky appearance on MRI. We call it a starry sky appearance. Remember that as well for a next time MCQ. Now, an 80-year-old patient with cerebellar stroke is received by the neurosurgeon, and the neurosurgeon decides for a conservative management. What is the reason? So now that this answer completely depends on the choices. Choice A is that there is a hematoma of a diameter greater than 3 centimeters. Listen, this patient of a cerebellar stroke with a 3 centimeter hematoma would likely not be conscious at all. The patient would likely be in a very severe state of coma, possibly already dead, because 3 centimeters is a huge amount of space for space occupation for the posterior fossa or the cerebellum. Remember, the brainstem is right in front and the tentorium is on top. So this 3 centimeter hematoma will compress the brainstem much before the patient can even make it to the hospital. So A would definitely not be a choice for a conservative management. And B is advanced stage increased morbidity, which is usually used in maybe stage 4 cancer. But in neurosurgery now, there is no advanced age that decides whether we should operate the patient or not. If an 80-year-old person who's otherwise very well settled in life, that person has a good life, we need to give them the chance, or at least the choice that we need to that we can save them. And I have saved patients at 80, even at about 85. The oldest I've operated for head injury is 90 plus. So we've given them a choice and they do well. So C is a good answer. Small hematoma, no edema. So what is the size of hematoma? Well, in the posterior fossa, no hematoma size is actually described as too small or too large. We generally go by the GCS and the edema that we can see. Remember, a hematoma in the supratentorial compartment, not in the cerebellum, in the cerebellar lobes and above the tentorium, of greater than 30 cc in size is generally indicated for surgery regardless of GCS, because it is too large and it can suddenly lead to edema. Below 30 cc in size, we generally think of many other criteria, such as whether it is close to the surface, whether it is 2 centimeters from the surface, whether in what area it is, whether it's an eloquent area, not an eloquent area, and the patient's GCS. But in the posterior fossa, even a 10 cc or a 5 cc or 15 cc of volume of clot can be life-threatening. So we generally go by other criteria. Now, there are some authors that have written criteria such as that is indications of what is called a packed posterior fossa. But let's not go into that. I don't want to go into that in so much detail, because many of you are students who won't go into so much details with neurosurgery, and it's not expected either. So the answer should be simple to most people. Small hematoma, no edema, manage the patient conservatively. Never worry about age or morbidity in neurosurgery. It all depends on the patient's GCS, which they have not given. Intracranial lesion on the motor area of the brain. Which investigation to be done for planning surgery so that there is minimum motor deficit? Beautiful question. We've only managed to figure out 2 choices: MR spectroscopy and functional MRI. The answer to this would definitely be functional MRI. See, this question basically tests whether you know the different kinds of MRI, and we've discussed this in our lectures. So, in a functional MRI, you come to know from the patient's actions what areas of the brain are stimulated according to how much blood flow is going through that area. For example, when it's done, and you should see this being done because it's a wonderful process. When the patient goes into the MRI, the person who's conducting the MRI will ask the patient to lift a finger, then wiggle their toes, then say something, and then it is found out in the MRI where more blood flow is happening according to Brownian motion, and these areas then delineated. And it is important because you can make out the exact motor area of the hand, the motor area of the lower limbs, and the speech area on a functional MRI. And in good centers like ours, we routinely use functional MRIs for low-grade gliomas and other tumors or meningiomas that are close to these areas that can be partially resected, that we know are going to grow slowly, that we know that we don't want to take out at any cost. And when such a thing happens, functional MRIs will clearly show us a nice mapping, which can then be used along with neuronavigation to pinpoint intraoperatively using a map. This is a place I do not want to cut out from this patient. And it is often used in conjunction with what is called awake brain surgery. The patient is awake during the surgery. And there's nice photos of this. I've shown them in my lectures of patients playing the guitar and playing the violin while their brain is being operated for a tumor, so that they don't lose this function particularly. If it starts to get lost during the surgery, then the surgeon just leaves it right there. So functional MRI is the common investigation of choice for this. There are others. There's SPECT, and there's brain mapping. But in this choice, I think functional is also the most commonly used in the world over. So that brings us to the end of our small recall session. I would say, other than the NASIS question, I think all the questions that have come have been discussed in our lecture series, which makes me very happy. The NASIS question also, I would suggest it is a sort of trick question, because they don't really expect you to know a study from the 1980s. What they want you to know is whether you should give methylprednisolone and how much methylprednisolone to give. Even the choices they've given, though, is fairly controversial. So if you've gone through the lectures, then you can answer all the questions except maybe one or two. And that is more than enough for you to place well in your examination. So here's to next time. Cheers and thank you.